and chief editor of Human Anatomy. After retirement, I had the good luck to be a teacher of Chirag Verma and his examiner as well. He is doing an excellent job by organizing international updates on various topics. I wish him and all the speakers and audiences good luck and good time. Thank you very much. Thank you.
Thank you so much, ma'am. It's a pleasure to have you with us.
Okay. Thank you. Thank you.
Thank you so much, ma'am, that you are here to bless us, and thank you for being our patron all the time. Like last year also you were there to bless participants and us for being a healthy summit, and also in 2019 you were also there with us. So thank you so much, ma'am, for every time blessing us, and hope we wish your good health in future as well, so that you can be with us all the time. Thank you, ma'am.
Okay. Thank you. Thank you.
And I would like to request Dr. Shekhar Abdullah to say a few words.
Good morning, everybody. Thank you to invite me for this summit. I'm so glad to be with you. The anniversary of this morning, uh, I try to do the most important that I do with all the bad situations here in Lebanon. I think, as you see, from 2 minutes ago, the electricity was down. I tried to see and then hope I will be all the time with you. Thanks very much for your invitation, and wish you all success forever. Thank you. Have a good day.
Yeah. I would like to thank you, Dr. Shekhar. Dr. Shekhar is from Lebanon. I would like to request Dr. Abhishek to say a few words. He is our joint secretary for the summit.
Good morning, all. As we are again in the new era of our second web summit, we have a pleasure meet to our resource persons as well as our speakers. And I would like to thank everyone to join our second world best, biggest international e-conference organized by Academy of Exercise, Health and Therapy. So thank you so much. And I think we have to start.
Thank you, Dr. Abhishek.
So I would thank you, Dr. Abhishek. I would like to request Dr. Pallavi, the chairperson of Neuro Colloquium, to please grace the summit by her words, and by telling everyone that her full profession. Dr. Pallavi is a principal and in charge.
Yes.
Yeah, Dr. Pallavi, just wait for
Yeah.
1 minute.
Yeah. Good morning.
Yeah. So firstly, I brief about Dr. Pallavi. Dr. Pallavi, wait for 1 second. Yeah, Dr. Pallavi is a principal in charge, College of Physiotherapy and Medical Sciences, and center advisor and protocol manager in DPR Center, Guwahati. And she is a coordinator of Indian Association of Physiotherapists, Women's Cell Assam branch. So we are much delighted that Dr. Pallavi is our chairperson in Neuro Colloquium, as well as our co-chairperson is Dr. Harpreet Singh. He's MPT Neuro and Physiotherapist Department of Neurology, AIMS, New Delhi. So I would like to request all of them to commence the session. And our first speaker is Dr. Chris Collins and Dr. Ashley Wensley. And their topic is SRT therapy. And both speakers are from Arizona, USA.
Hey, everybody. Thank you so much for having us on. My partner is unfortunately not able to attend today, but yeah, as the doctor said, we are from Arizona, United States. I just want to introduce a little bit about what SRT therapy is. It stands for Soft Stretch Release Techniques. It came about 3.5 years ago, so it's very new. My partner and I co-founded the company, and it came about from our own background in sports and our own injuries that we both experienced, pretty extensive injuries. She was a triathlete and she had a bunch of reconstructive surgery. The traditional physical therapy route and the medical field wasn't doing the best for her recovery. And that led her down the path of looking into much more of a holistic approach to the nervous system, to the fascial system, to the lymphatic system. And through my own injuries as a professional wrestler, I experienced a lot of neck issues, knee issues, and back issues. And so again, my background is a corrective exercise and movement specialist, as well as a neuromyofascial specialist. And SRT came about as an infusion between myofascial release work, lymphatic work, and fascial stretch therapy work. And so I'll dive a little bit into what we actually address and how we look at it. So our approach looks at 4 main systems. We look at the nervous system, first and foremost. We look at the fascial system. We look at the lymphatic system, and we look at the belief system. Our approach comes from a holistic Eastern meets Western, and it encompasses physical, emotional, and energetic. Now, one of the biggest things that we, in our own experience of injuries in the medical system, that we found, at least here in the United States, was missing was a connectivity or an interconnectivity between these 3 important pieces: the physical, the emotional, and the energetic. We have a lot of physical therapists or physiotherapists here in the US that only look at the physical body and they treat the physical body as a machine. And then we have a lot of psychologists or mental health therapists that look at it from an emotional standpoint, but they do nothing with the physical component. And then we have a lot of energy healers and Reiki practitioners and other energy workers that look at it from, or acupuncturists that look at it from an energy standpoint, but again, neglect other components of the body, such as the fascial system or the nervous system. And so the cases that we tend to work with when it comes to SRT are nervous system disorders, fibromyalgia, Lyme disease, lupus, RA. Unfortunately, we do see a lot of people, women particularly, some men, who have sexual trauma. They've either been raped, abused, or molested. And that really dives into the nervous system and the belief system. So we try not to specifically have any systematic protocol, because we recognize that every single person that comes to us for a session has an entire individual experience, whether that's 30 years, 40 years, 60 years. Their body, their nervous system, their fascial tissue, their emotions, their feelings, their energy, all have a very individual amount of experiences or trauma that they have gone through. So while physical approaches work for X amount and energetic approaches work for X amount, what we found is that nothing works 100%, because there's always an individual component that tends to be missing. And so when we look at it from the nervous system, we understand that the nervous system, we're working with the peripheral nervous system. We want to install new feelings, new sensory input for the body, especially if we have somebody who's in chronic pain, especially if we have somebody who is a trauma or abuse victim. They're not going to feel safe they're not going to trust somebody touching their body or manipulating their body. And so our first priority is to understand that through the nervous system, we have to introduce a feeling of trust, safety, security, and comfort. We do that by using extremely soft and gentle physical applications because we are trying to work with their nervous system. In terms of doing that, again, I might spend 15 minutes applying one technique in a rhythmic, soft, gentle approach, almost as if I'm trying to rock a baby to sleep. So I know that when we work with their nervous system, it has a dictation to the muscular system. So instead of massage therapy, where I'm trying to specifically go in and force a muscle to relax itself, I'm working with the nervous system so that the nervous system can decide when it needs to shift from sympathetic into parasympathetic, when it starts to feel safe with the practitioner who's working with them. And as their body starts to feel safe, just as if we were holding a small child who was crying, we're not going to shake it. I'm going to hold it to my chest. I'm going to rock it. I'm going to make the child feel safe. When it feels safe, it shifts from sympathetic to parasympathetic. The baby or the child will decide when it feels ready to stop crying and to start letting go. So we approach every individual in the same manner. We're looking at how does their body feel? What does the tension feel like in their tissue? Is there a nervous system jump if I put my hand on a certain body part, whether it's their hips or their back or their shoulders or the neck? Where does the trauma come from? Where do they experience it? But what is it attached to? Not just from physical, but possibly from emotional or from energetic as well. Because depending on where that root cause comes from is going to dictate where we move into the session, how much physical work we do versus how much energetic or emotional work we might do. And so we do have a system of stretch therapy and gentle myofascial release techniques that we use for the physical body, while also addressing and understanding that we are working with neuroplasticity. We are trying to create a new experience for the body, the mind, and the soul, for them to realize that this is a safe space. It's not a car mechanic shop. They're not coming to me just to simply fix their body. It takes a much deeper approach into the belief system, the nervous system, and understanding that if we cannot relax the nervous system, if it's locked into fight or flight, then they're going to have all kinds of other hormone chemical releases that are going on. They're going to have tight tension in their muscles. They're going to have other things that are affecting their fascia. And so first priority is working with the nervous system to make them feel safe, comfortable, and trusting. Once we can move past that component, it kind of works hand in hand with the fascial system. So I personally have seen 20 different people with the same lower back pain, but it comes from 20 different root causes. Some of it's very energetic, some of it is emotional, some of it is very physical. Some of it has come from whiplash from their neck, and it's affected their back based on how the fascia is pulling. Some of it has come from C-sections with pregnancy, and it's damaged their deep fascia, and the scar tissue has intertwined itself, and that's pulling on the fascia at the low back. Some of it has come from emotional trauma or abuse. If a woman has been raped or molested, it's going to have a big effect in that sacral root chakra, sacral chakra, low back, lumbar, and pelvic area. So understanding what each individual has gone through, and it does take more time to build that trust and to dive into it, but we try to have people understand that there is no one system that will ever work for everybody. And if there is a system, it's neglecting certain parts of the emotional and the energetic experiences that each individual has ever gone through. Some people understand it, some people don't. Some people feel amazing after 1 or 2 sessions. Some people, if we're working with a stubborn belief system and they're programming in their mind from years of abuse or from years of failed medical practice, drugs and surgeries hasn't worked and they're still in chronic pain, we're working with their belief system now because their belief that nobody can help them is going to be one of the things that we have to overcome, and that we have to start to shift their mindset and their belief system into there's things out there that you haven't tried. You just have to find the right pieces to the puzzle. And when you find those puzzle pieces, now we have to figure out how to put those pieces together for the big picture for them. And so when we look at it from the nervous system and the fascial system, it would appear on the surface to be a very, very gentle form of almost Thai massage. It's not aggressive. It's not forceful. Our goal is to work with the body, not against it. And we also want to be weary and cautious of bringing our energy into a session with another client. So energy is transferable. You can take energy from the client can take energy from you. You've probably been to a party or you've worked with clients before, and after the client, you just feel exhausted. They've drained your energy. It was this energy transfer that they took your energy, or you've been around people that lift your energy. So energy lies at the center of everything. We know that, medical community knows that. We know that cellular energy, everything has energy to it. So when we work with energy, we have to understand the transference is going to work both ways. If I have a bad day and I'm in a rough spot mentally, I need to clear my energy before I go into that session, because I don't want to put my hands on somebody or even come into their energetic vicinity and cause them anxiousness, nervousness, anger, or loneliness, depression, whatever it is that I might be feeling. I don't want that to come off to them, just like I need to protect myself and I don't want their energy to infiltrate my energy. So that's a big piece of what we do as well. We understand that the energetic component fuels and also manifests into the physical, and it's constantly transferable. So as we work with that, we also want to understand that the lymphatic system, because we touch and we do myofascial work, but it is so gentle in the approach that we do it, it would almost be considered lymphatic touching, very gentle. And as we work through the SRT protocols or through the SRT methodology, we can also add a sequencing of lymphatic work to address, again, the lymph system, which we know affects the immune system. And so by working with the 4 systems primarily of nervous system, fascial system, lymphatic system, and belief system, we're actually working with more secondary systems, such as the musculoskeletal system, the immune system, the circulatory system. And again, we're addressing the energetic and emotional bodies through the belief system. So it is a lot that comes into play. We've spent 3.5 years developing the approach to how we do this, why we do it. We have our case studies of clientele that have come to us from other physical therapists, that have come to us from post surgeries that have left them worse than before they went into surgery. Unfortunately, we know that happens. And in sometimes a matter of 5 or 6 sessions, by working with their belief system, by working with their nervous system, by calming their system and building that trust that they're not going to get hurt, that they don't have to protect themselves, that their nervous system can let go and allow somebody else to move their body, whether we're trying to manipulate certain joints or we're trying to increase fascial stretching. Whatever it is our focus is, it comes down to they have to be able to trust and feel safe, because if they don't, there will always be an element of you working against their body and their body trying to protect from whatever it is you're doing. So our focus comes around to those 4 systems. And as we do that, as we've done it ourselves, we've gotten to the point where, and I'm not sure how many of you are in the energetic realm or, you know, work with energy and that component of the body. But for those of you that do or that are interested in it, we have found some of the best healing processes come from when the client understands that they have the power of healing within themselves, because all we simply do are create guidelines or the ability to assist in their healing process. Nothing we do, at least from our component, is the sole purpose of healing. So I'm not coming into a session trying to fix somebody. I'm coming into a session trying to say, where are you in this moment? What has your body gone through? What has your mind gone through? What has your feelings, emotions, and energy gone through that has led you to this moment in time? When we know that, then we can start to address or peel those layers back. And we have seen some very powerful results by doing this. I will quickly share a story that I had with a client who broke her ankle. She had a trimalleolar fracture. And she went to the doctor and she had it repaired and she was in physical therapy. And I got the notes. She came to see me and I said, well, you told the physical therapist that your injury occurred because you fell, and you told me your injury occurred because of something else. So who are you lying to? Because I talk about the energy and the emotional component and traditional physical therapists don't. She didn't feel the need to tell them the truth because she didn't think it had anything to do with the matter of her issue. So in reality, what had happened was she was in an argument with her ex-boyfriend. He became aggressive. He started to choke her. She tried to get away and she broke her ankle. With that scenario, there comes an entirely complex emotional and energetic component to that physical injury. And what happened was every single night for 5 months after the surgery, she would experience pain in her ankle. She would feel fine throughout the day. Physical therapy felt good throughout the day. She was strengthening it. It was tight still. We were doing our fascial work and our energetic work. But every single night she would feel pain. And so knowing from the energetic standpoint that there was a lot of negative energy, anger, rage, violence, all of that was trapped in her bedroom, which was where the injury occurred. So something as simple as going home and using Palo Santo or sage to cleanse the energy from her bedroom and to command that energy leave her space and invite positive energy, love, and light into the space literally helped the pain go away. I followed up with her 2-3 days later. She said she hasn't had pain since she cleansed her room. And I made a joke. I said, go tell your physical therapist what you did to get rid of that pain, because a lot of PTs, especially here in the United States, don't believe in the energetic component. Even though we know stress can give you heart attacks. Stress can kill you. There's broken heart syndrome. You can die from broken heart and loneliness. So if that is medically proven, that stress, the feeling and the emotion of stress can affect your physical health, why can't depression, sadness, loneliness, anger, hatred, all of those feelings and emotions will have a physical effect on the body. And so that is one of the biggest approaches that we look at. It's one of the biggest differences when it comes to what SRT therapy is. Like I said, we operate in between the realms of fascial stretching, myofascial release work, energy work, and if you want, lymphatic massage or Thai massage work. So it looks and resembles different components from different modalities, but our philosophy to it is so much more in depth, and we focus on trying to understand and educate the client that we're here to help. And if what we have doesn't help you, there's something else out there that does help you. We refer to physical therapists all the time. We refer to acupuncturists and massage therapists. But we just want to let people know that as we grow and as we continue to expand, we have SRT professionals in Iceland. We have a few SRT professionals in Canada. And we have SRT professionals in the United States. And so as we grow, our goal is to share what SRT therapy is, how powerful we have seen it in terms of helping these people who are kind of off to the side or who have been left off the traditional medical radar because, you know, they have fibromyalgia or they have Lyme, or, you know, a lot of people who have sexual trauma don't get the proper help that they need. So that's what SRT therapy is in a nutshell. Again, it stands for soft stretch release techniques. We work with the 4 systems: nervous system, fascial system, lymphatic system, and the belief system. We combine the energy, the emotional, and the physical for each individual session. There is no session that's the same. There is no session that's identical. We do have a variety of physical applications that we utilize, but it really comes down to what does each individual client need and how can they benefit from the modality or the tools that we're using. Is it more energetic? Is it more physical? What is it that they need in the session that we see them? And everything is an assessment and everything is an application. So that's how we look at it. I want to thank you guys. I know I'm at my half-hour limit, so thank you guys for having me on and speaking with you. If you're interested, you can check out our website, srttherapy.com, and learn a little bit more about us and what we do. And our hope is once COVID starts to clear, to get out to India and do some seminars and certifications for some of the therapists out in India, because I know there's a high demand for healing in a lot of different countries, and it's something that we want to share with everybody else out there.
Thank you.
Thank you.
Thank you. Vote. We are not hearing anything.
Yeah. Chris, you have finished, I think.
Yes, Chris session is finished. Please invite Dr. Hariharan for his session.
Yeah.
Yeah.
Okay. Sir, I'll introduce you first.
Sure.
I'll just wait for 1 second. And Dr. Saurabh, I would like to request Dr. Abhishek you are the host right now. I think mute Dr. Krishna Garg.
Okay. Oh dear, I am not a host here. Costo.
Yeah, I think all are muted. So I would, Dr. Harrier, you can unmute yourself.
Yes,
And,
I'm.
yeah. So firstly, I'll introduce Dr. Harrier to all of you. Sir, you are more than welcome.
Thank you.
Second International Web Physio Summit 2021, organized by Academy of Exercise Health and Therapy in collaboration with Assam Downtown University, as well as the European Register of Therapists as an academic partner, and Osteopro and Osteopathy Association of Europe, Italy, Europe. So Dr. Harihar is actually professor in Bhai Kaka University, KM Patel College of Physiotherapy, and he is the head over there, Gujarat. KM Patel Institute of Physiotherapy, Bhai Kaka University, Gujarat. So he's principal and head over there. So I would like to welcome you, sir, and as well as I'll request Dr. Pallavi to say a few words. If Dr. Pallavi is listening to me.
Yes, I'm here. Yes. So good morning, everyone. I would like to welcome Dr. Harihar for his session now. And I must say that the whole session is going on very nice. And hopefully we will come to know about more and more beautiful topics in the coming time. So I would like to request sir to start with the presentation. Thank you so much.
Thank you. Thank you so much.
Yes, sir.
Thanks for the opportunity given. Just to check,
Yes,
my voice is clear. Can someone confirm it? Am I audible clearly? Yes, thank you. And my slides are visible? My slides too are visible?
Yes, sir, it is visible.
Yes, sir. Yes, sir.
Right, it's moving too, right? I could able to switch on to the next slides, right?
Yes, right.
Thank you so much. At the outset, let me thank all the organizers, Dr. Chirag from Academy of Exercise, Health and Therapy, and then the university from the Assam Downtown, and all the people who have been involved in this second Physio Web Summit. And the first Physio Summit, I had an opportunity to be there as a speaker, and again for the second one. And it was really a pleasure listening over there to all the speakers in the first International Web Summit. And again, this is the second one. It is always a pleasure to be associated with intellectuals who want to give something, learn something, and give their best to the profession for the betterment of the overall community. And it was interesting to listen to Chris as well about all this. He pointed out about all the stress factors influencing the fascia tightness. It was always, pleasure to listen to many people across the globe. And today, when Dr. Chirag approached me, I thought of an important topic, that is clinical dilemmas in prescription of assistive devices. I think everybody will be agreeing to me, we as physiotherapists sometimes work as a uni-professional, whether we are the whole and sole responsible person for the, making the patient able back to his toes and give him a comfortable life. Sometimes we become a part of a team. We are into multi-professional team also. There are more than one professional. Other than the physiotherapist, you may be having a surgeon in the team, you may be having a pediatrician in the team, and you may be having an assistive technologist in the team. That is multi-professional. And beyond that, nowadays in today's practice, there is a quantum shift in the management of patient. That is, we have moved from a physician-centric to patient-centric approach. By saying this, I mean that we take into consideration the patient's needs, his interests, and his priorities are to be considered. So it is mostly now towards patient-centric approach. And in that approach, the most important part is interprofessional approach. Interprofessional approach meaning collaborative practice. The difference between multi-professional and interprofessional, I'm sure many of you on this forum must be knowing, but to throw a little bit simple factor which differentiates multi-professional from interprofessional approaches. In multi-professional approach, there is one thing which is missing, that is communication. Here in our department, we treat and then we refer the patient to an orthopedic surgeon or to a special educator or as per the need, and there will be no much of interaction happening between them. But in interprofessional team, the most important factor is that we are communicating within the professionals, within the professionals, that what is the need, and we keep the patient in the center and surrounded by all the professionals. And one of the important factors is giving them some assistive devices when we need, and that too, especially in neurological condition, which causes long-term disability, or there is a lot of time which is taken place for putting the patient from back to his, from his disability to making him able. It needs a lot of time. So there is always a challenge, a dilemma of prescribing the artificial intelligence. It can be a hard device or it can be a soft device. So I'm just going to give a small insight. It is a half-an-hour program. So I'm just wanted to enlighten or to share my ideas and views, how we take a call on giving such prescription in such cases where the dilemmas and ethical concerns are there, and how we overcome and how we plan. And that is what is, and it is a It is a topic by itself as a huge area where we need to do a lot of work. But this platform, I'm taking it an opportunity for everyone to think over. And after this half an hour talk, probably many people will start thinking about it, how to go about it. Before I enter into the topic, I would like to share what Silvers in the year 1995 talked about it. I just want to reiterate every sentence so that we don't miss it. Let me read for you and others can read from the screen. In the everyday life of persons mobilizing in wheelchair, their inequality, both as experienced by them and in the eyes of the others. You know, we see a person more than anything. We first see the wheelchair, then the person, unfortunately, manifests itself not in the ability to walk, but in exclusion from using the bathrooms, from theaters, from transportation, from places to place, and from life-saving medical treatment. He needs to go across, he needs to be included in the society. Let me put a question that what Silvers is putting it. Suppose that most person used wheelchairs. Let's see, majority of the individuals in the country, in the globe are using wheelchairs. Would we continue to build staircases rather than the ramps? It's a matter to think over. Probably then there will be no staircases across, there are only ramps or lifts across. Since they are now in the minority, so we don't consider their challenges. But you know, thanks to the medical interventions, now we could able to save people's life. And now, and when we say this, the mortality has come down, but the morbidity rate has increased. So people live for years, but the quality of life goes down. They live with a lot of disability. Previously, what happens because of the lack of medical advancements, people die. So disability is also less. But now due to medical advancements, people survive. But survival is just not an important aspect, as someone has already said. You know, physios add quality of life to the years that the persons survive. So in that case, these architectural barriers, these built environment plays a major role. That is what I'm going to just highlight about it. The objectives are very simple. What is the need? What are the dilemmas and ethical concerns, and what are the guidelines? Let me quickly go through it with the permission of the chair and the co-chair for this session. Let me introduce to the audience what is assistive technology. Sometimes we call it as, you know, person with prosthetist and orthotist. Now the term is much more dignified. We call them as assistive technologists. Any item, piece or an equipment or a product, whether it is acquired commercially off the shelf or modified or customized. This is to maintain, this is to meet the need of an individual, either to increase or maintain our functional capabilities. That is what is assistive technology. And now there is a public law also in place. Even the government of India, apart from talking about Skill India, Make in India, now probably many of you must be knowing it is Accessible India. We want social inclusions. So they have put a law also, any service that directly assists an individual, the disability, the selection, acquisition or use of an assistive technology device. So as a physiotherapist, we closely work in contact with various professionals, and one such professional is these people who provide a lot of assistive technology. It starts from a single knuckle bender splint to the maximum myoelectric arm or these artificial intelligences. Nowadays, there are some pieces which are all kept inside. The moment you think that I want to open my fingers, you need not have to do any muscle efforts. Like, you know how, example, a normal being, I want to get up from the chair. The moment I think I can get up, the muscle work assists me, helps me. But similarly, there are a lot of artificial intelligence which has come in place that the person thinks and the muscle starts relaxing, contracting, and make the patient move. So it becomes an important aspect. So now what is the clinical dilemma? Why I'm taking this? What is just a dilemma? Dilemma is, you know, you can see in the figure, you know, that is always a situation where you are lost between two choices, and that too, they both are unsatisfactorily an alternative. Here a vehicle says, do not follow me. And on the other side, a person says, keep left, in the sense where to go, whether to use this or not that. You know, it is always a dilemma, whether to prescribe such artificial devices, whether should I give him a splint or not, that becomes a big question. You know, they call it a catch-22 situation or a tight spot. We are confused as to what to give. And there are certain, I have just classified based on the various literatures and my experiences. Majorly, there are 5 dilemmas which happens. Number 1, evaluating needs and skills for assistive technology. That is a dilemma. Now, many people, are they highly skillful, qualified to meet out the needs? And acquiring assistive technology, you may feel that this can help the person. Do we have such resources? And third, selecting, designing, repairing, and fabricating assistive technology systems. You need to have that varieties, that opportunities, that array of availability. Then coordinated services with other therapies. As I told you, it is interprofessional. We have to collaborate. You need to have a team approach for that. Your physiotherapist has to communicate with the surgeon or this physio or this person who makes splint and everything, what is exactly needed. And more than that, the patient and the relatives, right? And training both individuals and with disabilities and those working with them to use the technology efficiently. You may provide a powered wheelchair to a person with higher spinal cord injuries, but is that person knowing how to operate it? Or if not, his relatives, his caretaker, the close, near and dear ones, they need to be highlighted about the use of such things. So technologies can be classified into two parts, hard technology and soft technology, and both are interlinked. Soft technologies without hard technology are ineffective. And the hard technology, when there is no much of software intervention into it, now it is all electronic gadgets. And now it is, as I told, artificial intelligence. It needs a lot of software inputs. So they both are highly dependent, and that makes the life of an individual much more easier, comfortable, and simpler. But whatever said and done, it needs a lot of inputs. Now that is clinical dilemma. Now I'm going to come to the ethical dilemma. What is that ethical dilemma? Sometimes ethical and legal, they are not the same. We sometimes, many times confuse with what is ethics and legal. They both are different. An ethical dilemma or an ethical paradox is a decision-making problem. That is, it is here in the clinical dilemma, it is between right and wrong. But here it is more than right, and both are sometimes acceptable. Both are sometimes preferable. The patient needs this. That is one thing you say. At the same time, the financial background of the patient is not that comfortable. Or you might have to compromise something while giving this. If not alone money, sometimes you might have to open up the part and give an invasive thing to go inside, which needs concern. So it is always, it's a complexity which arises out of the situational conflict, in which obeying one would result in transgressing other. You might have to lose something. You might have to compromise on something to give the better thing, which is of the two, which is going to give the betterment. That needs to be considered. That is what is ethical dilemma. And under the ethics, there are certain important points. I'm going to classify one by one quickly with the given time. The first is beneficence. As a surgeon, as a physician, as a physiotherapist, or for that matter, as a healthcare provider, we need to ensure that actions lead to good results that benefit others. Whatever that you are trying to intend to do means you have to give the benefit to the others. Identification of potential consequences of such application and balancing of positive and potentially harmful aspects to maximize benefit to individual. Ultimately, whenever you, even though you compromise certain things, but overall, the person, you have that higher factor impactment that I'm going to benefit the patient, that should be predominantly there. And failure to abide by the rules of beneficence rarely carries legal punishments. More than the legal punishments, it is your own conscience, your own, this is going to be better. You have to make legitimate decisions to promote the good for others, as Beauchamp in 2008 have pointed out. Second point is non-maleficence. Probably many of us, who have read the Hippocrates Oath, you can see the first statement is first do no harm. That is non-maleficence. That is that, as a good physiotherapist, if you can't able to do something good, let us keep that aside. By doing something, let us not harm the patient. We have been given the gift of life. For goodness sakes, let's protect it and respect it. And people come to us with a lot of hopes, and they look at us as something like next to God, or sometime even God. So we need to have this principle of not causing harm to others directly or through avoidance of actions. Even if you miss to do something, sometimes that you feel that this patient needs this one type of splint, or he needs some other professional's intervention. But just because, for vested interest that if I refer my patient to other people, probably I may be losing my clientage. So we don't even prescribe certain such cross references, or the needs are not taken care of. So we need to be careful that we need to abide by those rules where we have legal implications. And then the third point is autonomy. Autonomy is nothing but freedom. I have the freedom of action and choice. So when we say that we as physiotherapists, clinicians, healthcare provider, we need to understand in this 21st century, the patient too has the right. Nowadays, we talk about something called as SDM. I don't know how many of you know this short form, what SDM stands for. It means shared decision making. I happen to attend few of the conferences where these sort of conditions come in and people talk about it. Shared decision making is just not alone for people like you and me. It is all for people who belong to that LGBTQ people also, in the sense the patient has to be kept in the center, his concerns, his needs, his priorities, his family's needs, his own choices and decisions needs to be considered. So it is, as I told you in the beginning of the lecture, it is now moving from physician-centric to patient-centric approach, and patient's needs, his priorities and preferences needs to be absolutely taken into consideration before we take a decision on prescribing any of the assistive technology devices. And the next and the last one is the justice. What is justice? We need to have this egalitarian approach. Some in English it is called as egalitarian, which means each person should have the same level of material goods and services. It is not alone hold good for food or any other basic resources. Otherwise, also for such assistive technology. That's how this government has got a lot of initiatives like ADIP schemes and all, where there is free distribution of such assistive devices. It can be wheelchair, it can be AFOs, or it can be walkers, it can be multiple such devices are all available, which is distributed freely across certain or some organizations are into it. We need to give justification. I know that the basic needs, if a person is little bit ambulant and other person needs are compromised, you need to first address to the other person who cannot able to get out from the bed. At least this person is moving around, this other person is just on the bed. So the resources needs to be managed. It can hold good to certain organization, like as an organization over here in our hospital, we have certain limited funds which we want to give it to people. I have provided some devices to one person who is able to walk. At the same time, he wants to have much more sophisticated, but another patient is lying down on the bed, could not able to. The resource needs to be shifted from this person to the other person. You need to give justification, like it holds good in this COVID-19 period also. Nowadays the boosted dose, people are talking about it, but the scientists and researchers says that more than a person who takes a booster dose, it is that every person should have at least one dose, so that overall herd immunity develops. We need to equally distribute the resources. That is what is meant by justice. Now let me bring into the focus to all of you Rawls difference principle. This is again very, very important. It talks about inclusiveness. The main motivation is equal respect for persons. We have to take them together. The society needs to be having an universal design. Nowadays, if you see the buildings which are all constructed a decade before have less accessibility, but retrospectively, if we can do that. But at least the newer building structures, we need to ensure that there are wider doors. The bathrooms are all having wider doors. We're having ramps across, non-slippery floors, lower desk for the reception, where a person in the wheelchair can look at the receptionist and take his files. So social and economic inequities must be such that they are of the greatest benefit to the least advantaged members of the society. Now, even whatever said and done, we have given so many things to the people, but still there is something called as device abandonment. Even though you give, people are not using it. The success of assistive technology depends as much on the support received by the individual and how much they use it. They need to, one is that we need to provide such device which can come for his rescue to make him little bit useful, functional, and it is operable. Another is that the patient should be using it. That is also equally important. The patient should use that. There are 4 factors which are significantly important when we talk about device. Why the patient abandon? First is failure of providers to take consumers' opinions into account. Just because I have few lakhs of rupees and there is no much of needs of the patient, but I keep on producing something which is of no use to the patient. Another is that easy device procurement. That is that you have to have that availability of the resources, and it is, if it is over the counter things are available, people will take it and keep it over there stored, and they will not be using it, and other person who needs it will not be having it. Then poor device performance. We compromise the quality to reduce the and changes in consumers' needs or priorities. Nowadays, a click away, the patient needs to be sitting for longer hours than moving from one place to other place. So sometimes the needs and priorities needs to be taken care of. If you are not having a follow-up of what is the need, sometimes you may be producing the outdated equipments, which is of no use to the patient. So you need to keep us updated. And there are certain other concerns, that is your cost and benefit of this. The assistive technology used did not stigmatize them as disabled and detract from their autonomy. The problem is that, as I was telling in the very beginning, what Silvers has talked about, people in a wheelchair. How many of us first will look at the person's face, then the wheelchair? mostly the contrast is that immediately we look at the wheelchair, then we look into the person. We should, that's how we call it. We should not call a person as disabled person. We say that person with disability. We should not call the child a CP child. Rather, we should call as a child with cerebral palsy. So by saying this, we give importance to the person, not the disease. So we should not even say wheelchair bound person. Means you are stigmatizing the person, that the person is wheelchair. So first the wheelchair comes. We need to say a person on the wheelchair, or the person who uses wheelchair, a person who is on a wheelchair. Stigmatization. That is also another concern. People feel offended. They don't want to see. Many people, in my own experience, when we offer them that you have to be on the wheelchair or you need to use the crutches, they sometimes feel better. Let me be homebound. I can be just on the bed. I don't want to move around with the wheelchair or a walker around, which they feel stigmatized. So these are all certain other factors also which we need to take care of it. So it's in a nutshell, if you look into these barriers, what are this that which leads to dilemmas? It is when multiple areas are there. If you look into all these points, it is one about the attitude of the users, as I talked about, the psychological factors, stigma, and attitude of the donor. Sometimes they do it for the pride, or there may be lack of donors, lack of funds, or the problems of availability, and lack of facilities in the public transport system. You would have provided the person a wheelchair, but are these public transport system like in Delhi and some other places where you have this ramp which comes out of the bus so that the wheelchair can go in? But how many of the cities have such places, or how many of these important places like post office, schools, and other malls has a ramp over there? You may be providing all those structures. So probably that is another built environment problem. And physical problems in using assistive devices. The patient may not be understanding the software structure, how to use it, the knowledge, many multiple factors which becomes a barrier while you prescribe or when you want to use or give a assistive device. The message is what is distributed versus what is accomplished. So to conceptualize the distribution of AT, what should be the basis? The first is ethical decision making in clinical practice. That's very, very important. As I talked in the beginning, we should have this 4-level hierarchy model, which you can always look into the net. Another is the goal should be smarter goals. It should be specific to the need of the patient, should be measurable. You could be able to see the objective is met, then attainable. The person should be able to take that, reach that goal, what you intend to make him do. And it should be reliable and it should be time bound. The time is very, very crucial when to give this assistive devices. If the time is gone, the spasticity period is gone, or whenever you wanted to give, if the phase goes out, that becomes useless. So there are various other orthometrical characteristics also. That accessibility to the products, technology, and support are very, very important. And few more additional points to conclude. Focus on treatment goals. Consider social context where this person is living. Tie every activity to the functional. Ultimately, when we talk about physio, that's why we have more than differential diagnosis, provisional diagnosis, medical diagnosis. What the strength of a physiotherapist is physical and functional diagnosis, because we always look into this ICD-H model where the participation restriction levels in the social level is taken into consideration. Next is be creative and innovative. So let us think out of the box to give the person the best. Take every opportunity for patient education. Ultimately, it is just not alone by giving the devices. You need to educate the person how to use it, when to wean off, when to upgrade it. And next most important is keep the caregivers in the loop. Involve those family members, caretakers, so that they have a close follow-up and they can update it. And it is all a team approach. The overall success of any rehabilitation program depends on the contribution of all team members. That's how the keyword of this seminar, that webinar, is that it is the teamwork which makes the dream work. Because the dream that we have as a physiotherapist is we want to make our people, our clients, our patient to be functionally able. So it is not uni-professional, it is collaborative practice where multiple people comes into role. So to summarize, the ethical assistive device technology service provision is not the ultimate outcome of all our collaborations, but a vehicle to help achieve more noble goals, providing maximum independence, full participation in the society, and integration into local communities. Success in these areas results in increased quality of personal and professional spheres of life for people with disabilities using this assistive technology services. Remember, whatever that has been given, let us not get stigmatized. What matters most is how you see yourself. You should not put that is I mean is the patient. Your clients, your stakeholders. Talk to them. Give them that patient education input that you feel yourself high. never get stigmatized. The more you think positive in your mind, the more better you will be and more easy that you could able to overcome all those difficulties. So instruct the patients to have, this is very, very essential. And that's how I almost coming to the end of the slide. If anybody has any questions, you can please ask me. And that's the end of the lecture. If you have any queries, we can talk about it. Thank you so much for this opportunity. And I think I'm on time completing the 30th minute. Over to the organizers.
Thank you.
Thank you so much, sir. It was really an outstanding session presented by you. If anybody have any question, please ask to Dr. Hariharan, sir.
Or any inputs for that matter. I'm still on the learning phase. People who wanted
Yes,
to
sir,
share
really,
something, I'll be glad to know.
Really, you do amazing
It
things on
was,
this PPT. And literally, it was a very nice mottos given by you to dream committee for the physios.
Yeah, thank you. Thank you. Thanks to the chair.
Yes.
Thanks to the organizers. Thanks to all those who are available on this platform for listening to me.
So I would like to thank sir for giving such a good insight into this topic. Hopefully it will benefit all of us in long run. Thank you so much, sir.
Thank you. Thank you so much.
Thank you, Hariharan sir. And if anybody wants to ask any question, they can write in their chat box. So we'll ask from Dr. Hariharan and Dr. Hariharan will reply for that.
Definitely. Yeah, sure.
This Dr. Hariharan will wait for 2 minutes so that if anybody wants to ask any
I'll
question.
be more than happy. I'll be more than happy to answer or to get any inputs. Actually, this is a topic where we need to really think about it. I'm sure the audience must be, pondering. It's like, how a cow takes the thing and cut chewing. You keep on thinking about it. So we will leave the audience to think more and come up with their own ideas and make it bigger, because nowadays the younger generation are much more smarter in the technology use. So I'm sure in the coming years, physiotherapy will reach newer heights with the young generation, with all those technological background and knowledge and everything.
Sure, sir, sure. So our next speaker is Dr. Shekhar Bau Abdullah. He is from Lebanon. Dr. Shekhar Bau Abdullah is a physiotherapist, deputy, master manual therapy and osteopathy, and he is the first Secretary General of the Society of Arab Faculties and Institute of Physiotherapy. And he is a professor at Institute of Physiotherapy, St. Joseph University, Lebanon. So I would like to request Dr. Shekhar Bau Abdullah to please unmute yourself.
Okay. Good morning. Good morning, everybody.
Good morning, Dr. Abdullah.
Okay.
Good morning, sir.
And now my presentation is clear or already on the screen. Oh, I don't know what happened with me. Share.
Dr. Abdullah, there's an option share.
I think I have a problem with share. I don't know what's happened for the presentation. Okay, let me do something else. Technical problem.
Dr. Abdullah, he can be able to share screen with you.
Just waiting for Dr. Abdullah to connect.
I think some technical issues there.
Mr. Abdullah, can you hear us?
So, okay,
I
guys,
don't know what
just wait for a few
happened
minutes.
over
We
there.
will start his topic on neuro rehabilitation of COVID-19 patients admitted to intensive care unit. Outstanding topic for all the physios as well as healthcare professionals. Dr. Abdullah?
Yes,
Now
yes,
please.
sir.
Okay.
I'm trying to share the presentation, but I don't know what's happened with that. Why did it?
You click on to share screen, then allow your file to your computer.
Files. Advanced. This is basic presentation. Okay. Yeah, I think.
Yes, sir. It is visible now. Your screen
Yes,
is
sir, now
visible
it
to
is
us.
It's visible now.
Yes,
Okay.
you can start.
Okay. Thank you. I'm so sorry for this technical problem. Presentation was a research work with many articles right in the critical period of COVID-19. Try to find the importance of our work as a physiotherapist in this pandemic. That's why we talk about early neuro rehabilitation COVID-19 patients admitted to intensive care unit. As you know, coronavirus disease 19 caused by the severe acute respiratory syndrome, coronavirus 2, it's a major burden of ICU because of the high number of patients eventually requiring respiratory support measures. Also, most COVID patients are asymptomatic or experience mild illness, become severely ill, requiring oxygenotherapy. About 5% of cases are admitted to an ICU, where they acquire acute respiratory distress syndrome, ARDS. Our understanding of COVID-19 is still incomplete, as you know, everywhere, but evidence is indicating potential direct deleterious effects on the central and peripheral nervous system of the CPNS. Indeed, complex and long-lasting physical, cognitive, and functional impairment have observed after COVID-19. Also, we have this kind of prolonged ICU stay will involve sedation and immobilization. ICU stay is associated with musculoskeletal, pulmonary, cardiovascular, immunological, endocrine, and metabolic complications. That's why we show critical illness associated in neuromuscular abnormalities. That means atrophy muscle, decreased strength, reduced protein synthesis, and joint contraction. And you will see the sheet on the figure 1. The benefits of early multidisciplinary rehabilitation after an ICU stay have been shown to be advantageous in several clinical conditions. Early, defined as during and immediately after ICU discharge, rehabilitative interventions are fundamental for reducing the neurological burden of a disease that already heavily affects lung function with pulmonary fibrosis as long-term consequences. Also, in the benefit, we are ameliorating on the early rehabilitation, ameliorating the neuromuscular weakness to improve the efficiency of respiratory function as the respiratory muscle atrophy worsen lung capacity. This review briefly summarizes the polymorphic burden of COVID-19 and addresses possible early interventions that could minimize the neurological and the systematic impact. We collect this available literature by performing computer search of database, Medline, PubMed, etc., and we combine the relevant keywords, COVID-19, coronavirus, early rehabilitation, and we saw that. Then we address early rehabilitative interventions that could minimize the neurological impact of COVID-19. However, this knowledge continues to evolve and new data is being shared regularly and new recommendations may be provided as more evidence emerges. Our plan of this presentation, this is our plan. We will talk about CNS, PNS involvement, respiratory empowerment, cognitive empowerment, the rehabilitation strategies, the neurosensory stimulation, cognitive rehabilitation, and last but not least, respiratory support and physiotherapy. For the CNS involvement, COVID-19 can induce neurological sequelae by attacking the CNS a multifaceted way. This includes vascular injury, inflammatory injury, and direct neural injury. This neurological intrusion may be clinically silent because...
Dr. Abdullah, sorry to interrupt you in between. Your slideshow is not visible.
It's not visible.
Yeah, not visible. That's why. Sorry to interrupt you in between.
Now.
So it is visible. Okay. Please open your PPT.
It's okay.
Click on early rehabilitation on your file.
Your presentation is not visible. You have not opened the. Click on this link.
I click again. Let me
double click.
How? Let
you just stop the presentation and
okay now.
Do it.
It's okay.
No, not visible.
No, sir, you click on early neuro rehabilitation September 2021. Your PPT name.
So excuse me. So you need to share the window of the PPT, not the folder. So try sharing the window of your PPT. So where your PPT is there, so share that. Only share that part.
Let me check what's happened. I don't know what's happened today.
So it shares screen.
Oh.
So you'll see a window, your PPT window, you share that. Thank you.
I'm trying. I don't know what's happened. Presentation. Oh, more.
Dr. Abdullah, do one thing. Yeah, please exit from that and share again. So either it will be helpful for you.
That's why I'm doing. Let me. Okay, I close it. What's happened was where I am in this. Yo. Stop share. Okay. Share screen again. It's okay now.
Now click on this link.
It's okay.
Yeah, but we are visible. It is visible to us that early neuro rehabilitation September 2021. You have not opened your PPT. Please open that PPT.
It's okay.
Not visible. Might be Dr. Rishabh, but you are saying that is right and he is not able to do that, I think.
So like you stop sharing. Mister, you can stop sharing and
Okay,
then
I
again
stop
share
sharing.
the only window where the PPT is there. So we can all visualize the PPT there. Then everyone can see the PPT. Right now we can see only one folder where you have the presentation May 2021. So you stop
It's
sharing.
okay now.
Yes,
Now it is
yes,
visible,
yes,
sir.
yes. Yeah,
It's
yeah,
okay.
yeah. Thank
It's
you, thank you.
okay.
Yeah, yeah, it is
Yes,
visible.
I'm so sorry for this kind
No,
of.
no issues, no issues, no issues, sir.
Okay. Okay, I was talking about the CNS involvement. COVID-19 can induce neurological sequelae by attacking the CNS, and that includes vascular injury, inflammatory injury, and direct neural injury. The neurological intrusion may be clinically silent because of sedation and avoidance of certain diagnosis procedure to reduce the risk of class infection. Central, wait, little bit. The central nervous system adverse cerebrovascular events has been reported in the COVID-19 patients. We can show hypoxic, ischemic encephalopathy, neurological malformation, including acute cerebrovascular disease and impaired consciousness, and also hemorrhagic necrotic encephalopathy and mediotemporal epileptic encephalitis. The link between COVID-19 and cerebrovascular disease remains controversial, but many findings suggest that ischemic stroke occur in systemic highly prothrombic states. Also, in a French consecutive cases series of 58 severe acute COVID-19 patients, encephalopathy with prominent agitation, confusion, and corticospinal tract signs were observed in almost two-thirds of cases. Also, in 8 of this patient, enhancement of the leptomeningeal spaces, and we showed bilateral frontotemporal hypotension. A selective affinity of COVID-19 for the basal ganglia and limbic system has been reported in rodent models of encephalitis induced by intranasal inoculation. In humans, high anti-COVID-19 antibody were observed in cerebrospinal fluid of Parkinson's disease patients. Furthermore, using electron microscopy, the virus was detected on frontal lobe tissues. Also in the CNS involvement, we have suggested that coronavirus may cause damage of the dopaminergic system. And in some COVID-19, we altered may reflect a functional actinic mutism. In the peripheral nervous system, PNS involvement and critical care illnesses, several cases of post-COVID-19 acute polyneuropathy have been reported with electroclinical characteristics of Guillain-Barré syndrome that include acute inflammatory demyelinating and motor sensory axonal subtypes. Also, Mao and R proposed that anosmia, and agnosia in COVID-19 patients reflect involvement at the cranial nerve level. A large cases control study of COVID-19 presenting with smell and or taste disorder found that 15% reported concomitant nasal obstruction, indicating a dysfunction of the olfactory tract. Data are still lacking to prove a specific association between critical illness-related myopathy or neuropathy and COVID-19. However, data from the SARS indicated that myopathies with severe muscle wasting and myalgias were frequently associated with COVID-19. Nearly of ICU patients, 15% present critical illness associated neuromuscular abnormality. And the most important thing is the respiratory impairment. COVID-19 causes varying degrees of lung complication from mild to severe pneumonia, RDS, and sepsis. In mild or uncomplicated illnesses, patients present many symptoms of upper respiratory, that means mild fever, dry cough, sore throat, nasal congestion, malaise, headache, and muscle pain. In severe pneumonia, fever is associated with serious dyspnea, respiratory distress, tachypnea, and hypoxia. In some patients, major alveolar damage, and we can show that on the sheet, results in hypoxemic acute respiratory failure, ARF, requiring mechanical ventilation and ICU admission. And research have also suggested involvement of the CNS respiratory centers. We can show also, we can see on the Shetla, the chest imaging result may be normal in early or mid disease, but the most frequent findings on X-ray and CT scan are space opacities, including ground glass opacity or consolidation. For the recovery, while the majority of patients recovered from pneumonia without any lasting lung damage, the lasting effects of COVID-19 associated pneumonia may be drastic. Following recovery from acute COVID-19, lung injury may lead to shortness of breath that takes months to get better. COVID-19 patients who recover from RDS may have lasting pulmonary scarring fibrosis, and we see that. In the cognitive impairment, neurocognitive impairments in COVID-19 patients have not yet been widely reported. The tendency of SARS-CoV-2 to invade and disseminate into the CNS may lead to severe neurological consequences. Recent findings of retrospective study of 14 COVID-19 patients describe various neurological manifestations. Several mechanisms such as hypoxemia, glucose dysregulation, effects of sedation contribute to development of neurological dysfunction. Older age and pre-existing cognitive conditions enhance the risk of developing encephalopathy during acute infection and critical illness. Following that, neurological dysfunction, including delirium and cognitive impairment, is extremely common, that we need attention, memory, processing speed, and executive function. Meningitis and encephalitis cases associated with SARS-CoV-2 demonstrate inflammation in the brain structure supporting memory functions. In patients suffering from conditions such as RDS, hypoxemia affects structure within the frontal circuit that are sensitive to resulting in deficit in executive abilities. Furthermore, clinical neurological examination of acute COVID-19 patients in the ICU revealed that severe forms of akinesia were frequently encountered. They may lead to clinical underestimation of conscious awareness in the acute phase, a condition described as cognitive motor dissociation. Rehabilitation strategies. This is the most important thing for us as a physiotherapist. Recovery, to enhance the recovery after COVID-19, rehabilitation is a complex intervention that focuses on reducing disability, decreasing dependency, and increasing the quality of life. Early rehabilitative interventions following COVID-19 should target recovery of the respiratory system, cardiovascular reconditioning, recovery of mobility, functioning, and cognition. And in this figure 2, we saw the rehabilitative intervention program should be implemented according to the framework of the International Classification of Functioning Disability and Health, which integrates an individualized treatment plan addressing personal functioning disease and disability. The early mobilization, that means the muscle deconditioning occurs very early with bed rest, decline in muscle mass, strength, and aerobic efficiency. ICU acquired weakness is found in 25% of patients. Early mobilization and physiotherapy is proven to be a benefit, safe, and effective intervention. Can be also initiated during the mechanical ventilation to counteract ICU acquired weakness. However, the method of early mobilization is mechanically ventilate patients is currently lacking, thus limiting reproducibility and dissemination of shared protocols. Official guidelines suggest the use of early mobilization protocols, but do not recommend a specific one. And we can we took two examples. We have the Motomed Leto R. It's an automatic system for leg movement and supine position that's mimicking a bicycle, allowing passive, active, or assisted mobilization. And also, the most important thing is the Ergo R. This light table with the integrated leg movement system allowing progressive verticalization. It's this that suggests that intermittent exposure to gravity through long period of bed rest. Also in the early mobilization, the most important thing, this is the multidisciplinary approach. That means not only the physiotherapists will work here, there is physiotherapists, physicians, nurses, all this staff work for the good situation of the patient. In the neurosensory stimulation approach, ICU for COVID-19 patients may lead to severe sensory deprivation, which can slow down the recovery and development of CNS function. We will have sensory deficits. Deficits can also stress the body and so alter its physiological balance. Therefore, treatment include enriching the environment using multisensory stimulation program to promote the brain's plasticity process, arousal, and behavioral responses. This sheet, we divided the sensory stimuli and some examples. For the tactile proprioceptive stimulation, we can massaging the patient's hands and legs. For the auditory stimulation, we can use the patient's favorite music, playing the voice of a loved one, and etc. For the visual stimulation, picture of a family member, a family film, etc. For the olfactory stimulation, we can use the patient's favorite aromas. For the gustatory stimulation, placing different kinds of food and flavor on the patient's lung with a cotton bud. The sensory stimulation is non-invasive, safe, inexpensive, and simple to apply rehabilitation approach. In the cognitive rehabilitation, that refers to therapeutic approach that address the cognitive deficit caused by the lesion or illness affecting the brain. Cognitive rehabilitation may be required for COVID-19 patients who present neurophysiological alteration in the acute and immediate post-acute. And here we can show the retroactive approach and the compensatory approach. The acute rehabilitative treatment of COVID-19 patients should aim to improve attention, stimulate the networks responsible for conscious perception, and stimulate the networks responsible for environmental interaction. That are increasing intensity and begin as soon after injury as possible, they are more likely to be successful. Okay. Other respiratory support and physiotherapy. The goal of early rehabilitation intervention to reduce breathing difficulties, relieve symptoms, easy and anxiety and depression, and lower the incidence of complications. And we can see all of these cases, what we can do with that. The rehabilitation therapy mainly includes position management, respiratory training, physical exercises, frequent changes of posture, passive mobilization, and or neuromuscular electrical stimulation should be planned, especially in the unconscious patient. Evaluation of exercise capacity and oxygenation response. Further suggestions include evaluation of peripheral muscle strength, measurement of joint range of motion, and manual and isokinetic muscle tests. Exercise involving a gradual load increase is recommended to regain normal function. And for patients bedridden or for extended periods, an assessment of balance function is especially recommended. And the recovery time is variable depending on degree of respiratory failure, physical dysfunction, and emotional function. Also, our understanding of COVID-19 is still incomplete in this conclusion. A growing body of evidence indicates potential deleterious effects of CNS and PNS function. This may lead to long-lasting physical, cognitive, and functional impairments. Beginning rehabilitation is the acute stage of the disease is required to combat this. Patients with severe COVID-19 are likely to present with a variety of serious sequelae, including prolonged stay in the ICU. That means immobilization, mechanical ventilation, tracheotomy, and sedation delirium. Rehabilitation will be a key component in the continuum of patient-centered care. Rehabilitation by a multidisciplinary team should start as early as possible since it has proven efficient in counteracting disease-related and indirect ICU side effects. Accordingly, individualized treatment plans should be implemented. Such program consists of a combination of approaches, including early mobilization, multimodal sensory and cognitive stimulation, tracheotomy, weaning strategies, cardiovascular training and monitoring, and respiratory management. These have been shown to improve functional outcomes and quality of life, reduce the social and emotional burdens for the patient and family, and reduce, the most important thing, the length of hospitalizations and related costs. Based on the experience of our acute interdisciplinary neurorehabilitation team in managing several brain injured patients. We would recommend applying an early and intensive rehabilitation program for severe COVID-19 patients aims at maximizing patient function to achieve the highest possible level of independence. And the figure 2 shows this effects of early rehabilitation. In this situation, I will thank you. I will thank our medical student, Farid Abu Abdallah, the Faculty of Medicine of St. Joseph University, who helped me in this presentation. This is me, Shakir Abu Abdallah, and thank you. And this is the all references of this presentation. Thank you so much. I'm sorry for this technical problem, and I'm so glad to be with you. I think it's time. Thank you.
Thank you, Dr. Abdullah. Thank you so much for your presentation. Wonderful presentation. If anybody wants to ask any question from Dr. Abdullah, he can reply. You can just write your question in chat box. Moreover, in that time, I would like to request Dr. Harihar to please answer that question.
By the way, I'm so sorry for this late time, okay? Please excuse me.
No issues, Dr. Abdullah. Thank you so much.
Thank you.
Dr. Harihar, I think, is not available. Okay. Dr. Rishabh Sharan is available. Dr. Rishabh, please unmute yourself. And I would like to introduce Dr. Rishabh Sharan.
Good morning, everyone.
Good morning, Dr. Rishabh. How are you?
I'm good. How are you?
Good morning. Good morning.
Thanks for the invite. And we are
Firstly,
amazing series of lectures.
Firstly, I would like to introduce Dr. Rishabh. Dr. Rishabh Sharan is MPT Neuro and PhD scholar, and is a certified NDTA therapist and CIMT therapist from the University of Alabama, Brigham, USA, and is a certified PNF level 1 and level 2 therapist from Switzerland, and is assistant professor in Department of Neurophysiotherapy, D.Y. Patil University, School of Physiotherapy, Nerul, Navi Mumbai.
We welcome you, sir, for today's session.
Thank you so much, ma'am.
Yes. So we will look into the whole presentation so that we can learn something good. Thank you so much.
Yeah, I'm looking forward to.
Yeah. Okay.
Yeah. So before starting, I would like to ask, is my screen visible and am I audible to everyone?
Yes,
sir.
My screen is visible?
Absolutely.
Visible. Family-based rehabilitation, a path ahead of stroke management.
Thank you so much. So family-based rehabilitation. Today, the topic is family-based rehabilitation, a path ahead for stroke management. So when we say family-based rehabilitation, and what do we mean by that? We'll be discussing today. And how is it relevant to stroke management? So when we talk about family-based rehabilitation, everyone will be thinking, yeah, what family? So do we want the family to be rehabilitated, or we want the family to be a part of rehabilitation? So as we know, we have heard of a topic or subject, you can say community-based rehabilitation, where we integrate the community for the rehabilitation of our patients. So similarly here now, we'll be thinking of in community. We were integrating family also. But here in family-based rehabilitation, our main focus will be that we are rehabilitating the patient through the family, where the family is being an active participant in the rehabilitation and helping the patient to lead. So again, we know so here what are we going to discuss? So what are the stroke issues and status? What is the rehabilitation for stroke? What are the expectations of patient, which is again very important? What are the barriers and facilities rehabilitation we are seeing? How these solutions are not met? And then master key to all problem, what is FBR, how to practice implementation, merits and demerits, and summary of FBR. So coming to the stroke. So as we know, stroke, can you all hear me now?
Yes, sir.
Okay, thank you. So stroke is a leading contributor to adult disability worldwide. So, but I have added critical to it. Why critical? Because something which is, one thing here is stroke is something which is insidious in onset. No one knows about when you are going to get a stroke. So it's something which occurs sudden, and here the patient is, one day he was all independent, the other day he becomes dependent on someone. And this is again very shocking for the patient. And after that also, in long run also, when we look into the rehabilitation, there are so many barriers to it. And in most of the cases, we are not achieving a complete recovery. There can be so many factors to it. So that's why we are calling it critical disability. So critical disability, again, where patient wants to do it, but he's unable to do it. So that creates lots of frustration to the patient also. Stroke, the other thing, the stroke possesses a significant personal, social, and financial global. I feel everyone agrees to it. Stroke is contributing 37.9% of the total neurological disease burden. And if we see how we are addressing this problem, again, this is a major concern. The other thing what we, again, which is shocking, is 6 lakh stroke survivors with disabilities are added every year. So again, we are seeing that this is something which stroke is, we know it's treatable through medical and surgical intervention, but later, one thing, the final answer to recovery after stroke is rehabilitation, whether it's physical therapy, occupational therapy, or a multidisciplinary team where we are involving speech language therapists, psychologists. So again, but then also we are not able to achieve the independence, and still we say that the patients are disabled. So why? We need to know that. So the most common and widely recognized impairment after stroke is motor impairment. Long-term problems are significant and contribute to an overall decrease in quality of life. Everyone agrees to it. Much of the focus of stroke rehabilitation on the recovery of impaired movement and related functions. So yes, so we have motor impairment. Because of motor impairment, what is happening at the end? Activity limitation and participation restriction is the main thing. In the rehabilitation context, physiotherapists have been the mediators of the motor recovery. So when we say physiotherapist, the main aim of a physiotherapist is to deal with the motor recovery, the motor part of. So looking at the problem list, again, stroke shouldn't be called as disease. It becomes a syndrome because you have so many things, mobility, problems in mobility, activities of daily living, to mental health and staying healthy. So in between, you can say that there's so many problems which are associated with stroke, and how this can be addressed. This can be addressed with only one healthcare professional, or we require many of them together. So do we require a MDT? And after having a multidisciplinary team, then also we are not able to address these. So who can address these problems? Again, so these were the problems which was faced by the patient, but we need to know that what crisis a family member also goes after stroke. So what are their health concerns? So as we have discussed, suddenness of stroke is again one thing which is a major concern. You know, the family never knows. We don't know that next day a family member will get a stroke. So this is again suddenness. We don't expect this. Because of that, what is happening? Significant functional loss is there. High level of care. The patient is completely dependent, so functional dependence, and then the discharge. So discharge is again, so article stated that the main crisis is, one thing is the suddenness of stroke, and the other thing, when the day the patient gets discharged and gets back to home, that is the next crisis a family member faces, because they don't know how to take care of a stroke patient. They have so many issues to it, and how this issue can be addressed. We should. So there are so many. We'll be thinking, oh, I as a physiotherapist, I am addressing. But as a whole, all the MDT team or all physiotherapists are addressing this or no. So when we have seen few researchers, we have got that only the interviews were taken through patient, and they have stated that only 22.2% of patients were addressed about how to take care after discharge. So again, this is a main problem which has to be addressed. The other thing, now coming to, we were talking about the global scenario. So looking at this is a graph which has been taken from the atlas of WHO, where they have represented the neuro rehabilitation services, the global scenario. And here what we see, that in in 105 countries, what we are seeing, only 16% neuro rehabilitation services are there. And the other thing what we see is stroke unit. Again, we don't know how many stroke units are there in India also. So 18%, they say, out of 105 countries. So you can say that only 18 countries have stroke units, only 16 countries have good neuro rehabilitation services, and only 17 countries on an average have a good neuro rehabilitation through general units. So we can see that how, as a physiotherapist, we are limited. We are not able to care the patient. So how can we cater all the stroke patient or all the patients with neurological disability? One thing what we know is every patient requires a long-term care. So how this long-term care, how this can be met? So again, coming to the expectation, what the family expects or the patient expects from a physiotherapist. So first thing, definitely improvement and recovery. They are looking back. So what is their main aim? That, doctor, can I get back to all my functions what I was doing before? So this is something which they look forward to. And this is, again, it depends on multiple factors. So you can understand the patient as well as the therapist. It becomes a problem for them because it's difficult to meet this need. Functional independence, able to get back to work, and overall, these are the main expectations. When we have asked patient, I have done interviews, these are the main expectations what the patient expect from rehabilitation. So again, what is the gateway to recovery? Personal factors are there. I told there are so many factors on which recovery depends. Family and network, professional support and intervention, social structures. But again, as a physiotherapist on a clinical setup, we can't address all these as an individual. So what can we, whom we comment means we are interacting the patient as well as their family members. Others, it's difficult again. So the easiest way how can we deal is dealing with the family members. So family members are the catalyst which can help us to facilitate the rehabilitation. So they can be a motivator, they can be a catalyst, they can facilitate the rehabilitation. How can they? So we'll be looking. So again, one thing I got 3 days back on social media, I just got this meme so whenever we say, okay, please follow the home exercise program, patient agreeing, in patient's head, no, I don't think I'll. So again, why no, I don't think I'll comes to the patient head. So this also, many a times there's multiple factor to it. Whatever exercises we are training the patient, it's difficult for him to do it at home, or he is not being taught well when I'm saying certain repetitions, or he's not understanding those complex movement. So it again becomes becomes difficult for him to practice this at home. So how this can be again dealt in a better way, so where we are involving the family and looking for that the family are trained well. So when I say trained well, this doesn't mean that we are training them to become a physical therapist, but we are training them on a regular basis that they learn the exercise well, or they supervise or facilitate the exercise through contacts, through manual contact, where they're just helping the patient to do the exercise, or they are just guiding through verbal stimuli that how well they can do the exercise. So these are the small steps how this home exercise program, from agreeing, just shaking head, to doing, we can reach through the family. So again, looking at the facilitators and barriers to rehabilitation, when we talk about, they are, so as we can see the seesaw, we have more barriers than facilitators. So we want the brain to be healthy, but at the end, what is happening in long term, the brain is relaxing, and if the brain is relaxing, we won't be able to treat the patient, we won't be able to get the patient back to normal. So looking at the facilitators, what facilitates? So definitely their expectations, what they have is facilitating them towards exercises. So improvement or recovery due to physiotherapy or due to any MT, functional independence, able to get back to regular work, overall health. This is one individual aspects. The other thing what they look is motivation to stroke peers. So success stories of other stroke patients, easy accessibility to physiotherapy, home visits, physiotherapy in clinic or hospital nearby. So that also helps them. Regular home program given by physiotherapists. If we are giving a regular home program, again, involvement of family members. If the family members are involved, it becomes much better. So these are the facilitators which patients have told us. So this is again through an interview we got to know about. So looking at the barriers here, what are the barriers? Again, there are so many added complications as we have discussed, the unlimited problems what they face. Again, it's unending pain or any health condition. Then again, this is a long-term rehabilitation. So financial constraint, lack of motivation, interest. If they are not educated well about the rehabilitation and how this will help, again, that creates a problem. Unable to visit the hospital clinic for physiotherapy for any reason. Unavailability of specialized physiotherapists, lack of explanation of role of physiotherapy. Again, vigorous rehabilitation, as we know, to have a neural plasticity for the brain to again activate, we need lots of intensity and duration of exercise. That creates again a barrier because not everyone is willing. So again, same thing, monotonous rehabilitation. So then if we are just making them do exercise on a regular basis, same exercise, how this has to, we have to make it interesting, how this can be dealt. Irregular physiotherapy sessions. Again, if the physiotherapy sessions are irregular because of any of the reason from the physiotherapist or the patient, change in hand because they are not able to get a same physiotherapist every time, language barrier, rehabilitation insurance. So again, this is lacking in most of the country. Government NGO funds for rehabilitation. If we have, we don't have the access to, we don't know how to reach for. The patient doesn't know. Even many of the therapists are unaware of. Then coming to how they are unable to visit the hospital clinic for physiotherapist. Again, health status, fear of infection induced by pandemic situation. So this was one thing which was creating a hindrance to rehabilitation, that they were having fear. They don't want to visit the physiotherapist because again, they have a dual burden. First, they are scared of getting the infection. The other thing is that they are immunocompromised because they have the long-term disability, their immunity is low. So getting a chance to be infected is more real. So no one to accompany you to hospital. Again, they don't have anyone who can take them to the hospital. So that has also been a major barrier too. And then transportation inconvenience, again, it's costly, difficult to move the patient into the vehicle, distance, environment around is not disabled friendly. So how these problems should be addressed? Again, there are research biases also. So when we looked into the research in stroke rehabilitation, the maximum research what we are able to do it as a PG students also, we have always been, we are more that okay, because there are so many limitations to it. Getting a long-term, a chronic stroke patient becomes difficult. So everyone ends up doing a research on acute care. Everyone stresses on more of acute care than long-term. Definitely acute care is very important, because if we deal the patient in the acute, the early screening and early intervention, if the patient gets all right, that's really good. But again, we see the course of stroke, the recovery period is long, it's prolonged. So anything which is done within 3 months, 6 months doesn't give us a final recovery to it. What happens, maybe the patient is recovering, but still the brain, you can see some symptoms recovering, but at the end the brain is not, we are not able to create a cortical mapping here. So seeing the research biases, the majority of stroke research has targeted acute care, and this has greatly improved short-term stroke outcome. So what will happen? We have a very good outcome, but after which what? We just fall. However, a variety of international effort is needed for better understanding of longer-term stroke problems in both research and practice in order to improve long-term care provided to stroke patients. So we are seeing since 1990s, and still now the WHO is working on getting something, a better plan for long-term care, and still we don't have the best one right now. Long-term care is neglected in most of the clinical scenario. Patient and family members get accustomed to the disability at the plateau stage. So what happens at the end? What the family members also gets tired because they are seeing there's no recovery to it. The patient is also, because of the plateau phase. But we need to know how to overcome this plateau phase, or how to change the exercise, and how to unleash the potential that we are not halting at. Because stroke, again, there are so many researchers which says that the patient can recover in any time frame. So again, this has to be used, this knowledge has to be used. WHO has regularly emphasized in long-term rehabilitation, but still concrete solution is missing. So when we see concrete solution is missing, so what can be the solution to it? So again, when we are talking about these quality of care proposed by WHO and many of the Western world, scope and extent of its long-term coverage, responding, so these things should be addressed. Responding to their needs for preventive and curative care, assessments of need from the patient and caregiver is again very important. So it shouldn't be, so when we are doing a goal setting, it should be where the family also, it's not only the patient and therapist planning the goal, even family should be, there should be some regulatory system to it, standards to protocol should be there. So agreement over outcome definitions, legitimate expectations, so there should be a fair treatment to effective coverage across disability. So again, meeting these are all again on papers, but in clinical scenario, how to get this, how? So again, we have seen there are so many burdens to it. The burdens are again unending. And if you want to give a solution to it, again, every solution has a different, every problem has a different solution. So like if you have a global burden, we need to prevent and aware. If the incidence is increasing, we need to have an effective rehabilitation. We are lacking again in resources, so we need to have a good resource plan. And any intervention, it is again, we are lacking in the therapeutic interventions also. So lacking in form of, we don't have specialized care, we don't have specialized trained physical therapist in stroke care. The other thing is long-term disability, then they require a vigorous rehabilitation, intensity, duration, everything has to be catered. So how are we going to cater this? Services and resources are scarce, early intervention is required, individualistic recovery state strategies should be there, caregiver support is missing, financial constraint is again a problem. Plateau, I have discussed, recovery plateaus reflect diminished capacity for additional motor improvement, warranting discharge. So you're more of task specific, repeated motor practice in real time environment. So we want the patient to practice in a real time environment where they are practicing in their home setting, in the community setting, what they'll be doing in their day-to-day life. Inadequate functional, so anything which is from clinic, it should go to the home where he's practicing. It shouldn't be in clinic what pegboards he's doing with us. Again, he needs to do some similar activity where he's trying to use the spoon, where he's trying to hold a glass. So anything, whatever is practice in the clinic, it needs to get into the real environment. So that has been always said by any of our neurophysiotherapists, whether it's Bobath, Brunstorm, or Edward Top, anyone from CIMT, everyone wants that whatever training is done in the clinic has to be practiced at home, and it has to be practiced in the real-time environment, that they are getting back to an activity. So again, we are seeing the solutions are so many, but how this can be, these solutions can be addressed: inadequate functional recovery in real-time environment, repeat practice in home and community environment, conditioning exercise. But how to address this? Who can address this? Only right now, the easiest way is training the family, because family is the one unit which stays with the patient. Caregivers, the care, there are so many, you'll say we should hire a caregiver. So yeah, that can be an option, but again, there's so many demerits to it. Again, there'll be financial constraint to it. The caregivers won't be a permanent solution to the disability because they are not staying permanently. So you're the family member. That's why we are not saying one person, family we are saying. So at least minimum two people, if they are being ready and helping the patient to actively participate. So now knowing what is FBR, so we have discussed so many problems, what are the barriers, what are the facilitators, how this has to be addressed. So coming to what FBR is. So FBR is something we need to come to a solution. How we have to come to a solution, it's up to us. Upar se jao, niche se jao, you want to go it from up in bit. But there should be some solution to this problem, the recovery, how this can be addressed. So FBR is what? FBR is a family-based, patient-centered approach. So it's involving family in a patient-centered approach. So at the end, patient priority, how we meet the priority through the family. Strategies involving active participation of patient's family member. We have heard lots about active participation of patient, but we want here participation of patient as well as the active participation of family, where they are helping us in the rehabilitation. So whatever they learn in our clinical setting or during our home visit, what we are training them, this has to be trained to the patient as well as to make the family member mindful of what we have trained it to the patient. So at least spending 10 minutes of our clinical time when we are treating the patient to make the family understand what they are going to do, what is their role, are they supervisors, what cues they can give, and handling can be trained. So again, this is this responsive and flexible home care rehabilitation. So what are we saying? This will be a responsive. Why it's responsive? Because we'll be increasing the frequency, repetition, duration of exercise, which is again a yes to rehabilitation. Why are we lacking? Because we are not able to give so much time to a patient. Neural plasticity says that the repetition and frequency, if it's increased, what CIMT says at the end, that we need to increase the repetition, then only it will be seen that change. If we want to make the change permanent, it has to be practiced a lot. So how this will be? Through FBR, if the family helps the patient to do the exercise with structured assigned roles to the member. It's not like that any random person is making the family do. So before we'll take a consent that if you really want to help, we need to explain the benefit and why we want the family members to be a part of it. And then we'll assign some role. So with structured assigned role to the members. So if two member, one person can work on upper limb, the other on lower limb, something walking. So when I'm saying upper limb, lower limb, rather we can say on hand function training, the other one is looking on something where he's mobilizing the patient. So looking up who can meet that job demand, we need to structure and give them a trained program, trained by physiotherapist, rehab specialist. So again, it should be trained. It shouldn't be a random that looking at some looking on the social media or some YouTube video and then starting. Again, that won't be very ethical, and it won't be enough until unless it comes from and it's tailor-made for that patient with frequent follow-ups. So again, it's not one day that we go and we train the patient and then okay, it's done for a lifetime. No, so we need to have a regular follow-ups to it. So again, we are cost cutting our visits to the therapist. Again, this is again because we know it's a long-term follow-up care stroke. If we want a patient, because at the end, as a physical therapist, what we are looking at, we want the patient to recover well. So with frequent follow-ups to improve patients' overall function, thereby improving quality of life. So yes, and finally, if patient's overall function is improving, he's having neural plasticity, we are able to address our concerns, whatever concerns we have discussed about stroke rehabilitation, we'll be able to address this through FBR. So again, regards to involvement of family members, we need to be mindful of facilitate exercise trained by physiotherapists. We are not saying every time that he's making the patient do, because we have spoken about that functional dependence is again a crisis, again a problem to a family member, because he gets scared of that. Now the patient is completely a burden on me. I have to take care of everything. Rather, he starts facilitating. If he facilitates an action, the patient will also start doing something, and he will be constantly motivated to do that. Consent should be important before involving family members in rehabilitation. Again, we need to have a consent. We need to consent the both, even the patient as well as these. So if the patient wants the family to be a part of and family wants to be a part, want to help the patient, both is important. What happens in regular setting, we just tell them that yeah, exercise you need to make them do these exercise, but we don't take the consent that they want to do it or which part they'll be easily doing it. If they are visiting one day with, we can ask that you can change your partners with whom you are coming, change the partners means change the family member with whom you are coming to for the rehabs, and you can keep on training them. So again, this will have a better long-term care. Patient and family members should be involved in setting short and long-term goals. Yes, we have discussed this. For a good plan, long-term plan, again, both their problems should be addressed, family as well as patient. Same family members performing the allotted exercise on an accountable and regular basis. So how many times we have given you this exercise? We ask the patient, do we ask the family member that how many times have performed this exercise, how regularly you have done in an accountable regular. So again, this will give them a ownership that they have to do it. If we make it accountable and regular, now they'll have the ownership to the patient, and from his room, he'll be everywhere in the place. He'll be everywhere in the place when I'm saying he'll be there in the home, and what is happening, the integration in the society, he'll be back to the society and he's getting better with. So again, how FBR will address the parameters of neural plasticity. So how it is addressing, again, we look at time sensitive critical period. So again, now we know that time sensitive also in acute care, we need vigorous rehabilitation. Later also we need vigorous rehabilitation. So time is not a constraint now. Before, time was a constraint. When I say time, recovery time I'm talking about. So anytime you can start with. So whether it's long-term or acute care, FBR can be practiced. Repetition, intensity, and time. Definitely, if in collaboration with the therapist, the family is also participating in the rehabilitation. And if each family member spends 15 to 20 minutes also, every family member has minimum of 2 members. So 20 minutes of exercise a day, 20 plus 20 is 40 minutes at home. And if patient also does 20, so 1 hour of exercise with 45 minutes or 1 hour of exercise with the therapist, definitely it will work and this will create a better care. Fine. Engagement, attention, motivation, again, he'll be engaged in activity at home, he'll get attention from the family member and be motivated by the family member. So this is again a very important factor for neuroplasticity. Generalized aerobics exercise. So if the family is participating in the rehabilitation, they'll get to know how to handle the patient. And because of that, again, we know aerobics exercises are very important for neural plasticity. Again, for angiogenesis, neurogenesis, for the neural plasticity, again, we need to have a good oxygenation to the brain. So this oxygenation will be met only through aerobic exercise. And again, we know one of the factor to stroke is the cardiac ailment. So cardiac ailment also will be addressed from here, because many a times what happens, we train the patient for the strength, but we are not training them for the endurance. So from here, the endurance will come and then he'll be able to do the activity. If we want him to get back to, we want the lady to get back to the kitchen, he won't. If she is not able to stand for 5 minutes, what's the use of, because you can't perform any activity within 5 minutes in our kitchen on long-term basis. Maybe short-term you can do it, but again for long-term, again, because it won't be meaningful for, it won't be smart, it won't be specific, measurable, accurate, realistic. So again, aerobic has to be, aerobic exercises can be addressed to the family, and then we are having a better long-term care too. As the heart starts recovering, the brain starts recovering, yeah, the patient will be back to the community And if he's back to the, yeah, we are able to achieve something, yeah, permanent change to the brain, the cortical mapping. Again, task specific training. So task specific training can be done in a real time environment where he tries to hold a dish, he tries to hold a, tries brooming, he tries doing simple activities like reaching something from the overhead cabin. So these things can be done. So whatever in CIMT we are trying. So what during task specific training, patient can assist, he can just give a cue. So like this, we are addressing the problem of the patient. So how to practice FBR? We can practice FBR through hands-on training of this exercise protocol, education, consent, types of exercise. We need to know that we need to have functional context exercises, ergonomic concern, patient handling techniques. We need to train for methods of assistance. How are we going to assist? Are we giving a cue? Are we giving assistance through our manual contact? Are we giving them resistance to that activity? How resistance can be given? So this we need to be aware of. Repetition, duration, and frequency is increasing through this. Then what is happening? Emphasis on activities or functional context. Again, we are looking at that everything is done in home-based environment. That is again beneficial for them. How to contact for queries to a physiotherapist. So if the family member is practicing FBR, if they have any queries, how this has to be addressed, then documenting the sessions. You need to keep on maintaining a record. You can just maintain an exercise diary, how many hours or how many minutes you have done the exercise, which part has been treated. So at least if after 15 days you get to know that these exercises were done and these are the benefits, or after doing these we are not able to met the benefit, so how to change these exercises. Yeah, how we read in manipulation that if it's not working we need to come up with a different approach. So here also it applies. Ways to give feedback and practice conditions. Again, I've told always feedback and practice condition to make a permanent change neuroplasticity, and then regular follow-up. So it's a very simple step how we can practice it. It's easy, everyone is doing, just we need to make it structured and in a accountable manner, accountable and flexible manner. So again, for optimum efficiency of the regime, some pertinent questions need to be answered before implementation. Is FBR appropriate for the client? Again, we need to look at that. Is it appropriate? If his vitals are not stable or anything, we need to look into it. Does the therapist have the skills and training to provide remote physiotherapist? So if the family member is not, he is only fragile, we can't expect. I'm so sorry, not the therapist I'm talking about, the family member. If it's fragile, if he's unable to understand what we want from, then it's difficult to practice. And again, the therapist needs to have the skills to train the family member as well as the patient. Are the techniques of FBR rooted? So how this can be addressed if we have a curriculum to it, if we have something in our academic part also, that this is again something which is relevant and this has to be practiced, then this will be, and we need more of evidences to it. Again, we need lots of research too. Are the techniques of FBR rooted in an evidence-based approach? Yeah, the second question. Can available assistive technology, morning only sir has discussed in detail, be incorporated into rehabilitation regimes to make them more efficient? Can some form of support in form of tele-rehabilitation be included for remote practicing of the management? How the immediate and long-term goals can be stipulated, and is the imparted rehabilitation model in synchronization with the expectations and caliber of the patient and the family member? So again, we just can't make a protocol and today I can tell you you are going to do this. No, we need to look at the expectation of the family members as well as the patient, and we need to caliber, we need to look at. So again, smart goals, specific, measurable, realistic, achievable, and time bound. So realistic and achievable are very important, that whatever we are setting, the goal has to be realistic, time bound, and achievable. Yeah. So again, there was an article. Again, FBR is a very good approach which can be practiced during the COVID time. As we have discussed, patient is having fear to come to these physical therapy. So this, I am not saying that he shouldn't, but we can cut down the session. So we have cut down the probability of getting infected. So in current uncertain times demand. So again, we are having an uncertain time. We never know what will happen next right now, demanding a need for social distancing. Implementation of a family-based model is very important. remote delivery of PT through guided family-based approach. So again, guided. So when we are saying family-based approach, it's always guided is an ideal model to support ongoing physiotherapist services during this period, especially the most vulnerable to the clients. Yeah, those who are. So again, coming to the summary, why FBR is important at the end, we are enhancing the adherence to rehabilitation. And if we want to coin a definition to FBR, it is a family-based, patient-centered approach. So a family-based. So here you can't see the patient anywhere in the house, and once the family is involved, the patient is everywhere. He's enjoying every bit of the house, and he is being so. At the end, what is happening? The quality of life is getting better. So what it is, a family-based, patient-centered approach involving active participation strategies of patients' family members for the accountable and flexible home care rehabilitation protocol, with structured assigned roles to the members who are trained by the physiotherapist or rehab specialist, with frequent follow-ups to improve patients' overall function following improvement in quality of life. So at the end, it's not a problem to a physiotherapist also. We are not saying that the family will become a physiotherapist, but they'll be guided by us. And at the end, why again FBR and stroke? I could have called FBR and everything, but in all, but stroke requires long-term care, and long-term care is not something, because it's something which can recover. In a motor neuron disease also FBR can be practiced, but not that the stroke has a chance to recover. Patient can get back normalcy, and getting them back as early as to avoid the dailies, the disability adjusted life. So again, we need some approach where we are helping them as early as to rehabilitate. So if any questions, I'm looking forward to, if you have any suggestions to it, I would really like to. I'm really sorry I have exceeded some 5 to 10 minutes of your, I'm sorry, Dr. Chirag.
No issues, sir, no issues.
Can you all hear me?
Pardon?
So someone wanted to ask about Parkinson's. Again, yes, it can be used each and everywhere. It can be used in a ONE also, where we know that the adherence, there's so many researchers when we see that adherence to exercise to a ONE also we don't have. So why not Parkinson's? Again, Parkinson's is a major disease where the body is completely involved. So it is beneficial everywhere. Why I came up with stroke was that here we know that recovery can be assured. This is something which is not progressive in nature, but again, Parkinson's, it will be progressive, but definitely it will help. Definitely it will be halting at least the progression too, because if we are having a good intervention too, because I can't say we will be able to treat Parkinson's through this. This will be the most acceptable model too. But for stroke, this can be yes.
Actually, it is streaming, so it takes 15 to 20 minutes to go over there in that town hall link. 15 to 20 seconds, sorry.
Not an issue. If you want, I can wait.
Yeah. We are waiting for the participants.
From the chairpersons, I would definitely like to have, so I can incorporate something better in FBR if you want to give me some pointers.
If any of our speaker as well, Dr. Shekhar, Abdullah, Dr. Pallavi, if you want to ask any question from Dr. Rishabh.
First of all, I would like to thank Dr. Rishabh for such a beautiful presentation. And I think the knowledge part from this presentation will help definitely our participants. And like it is some of the thing are new insight for the students in this practice. So from my side, there is no SS question, but I really appreciate the way of presentation and the knowledge you have given to our students. So thank you so much.
Thank you so much, ma'am, for your kind words. And I think no question is there. So I'd like to request Dr. Rishabh Sharan to please stop sharing your screen. Yeah. So thank you, Dr. Pallavi, for being the chairperson of this Neuro Colloquium. And this 2 days conference, like we can say International Web Physio Summit, is finishing this one colloquium. Am I audible?
Yes. Thank you so much.
Yeah.
Thank you. Yeah, and thanks for making me a part of this presentation. So thank you once again to ADTU for giving me this opportunity to be here. So thank you so much. I hope I'll meet all of you in future.
For
So
sure, ma'am. We'll be organizing not a virtual event next time. Hope this COVID will soon go, and we'll organize a conference in Delhi, and we'll be inviting you as well. We have organized a big conference
thank you.
in Jaipur in 2019 before COVID. And from last 2 years, we are organizing this summit. Like last year also, we had organized this first International Web Physio Summit. And around
Yes. I came to know about it.
yeah.
Yes.
So this year also we have
Thank
tried
you.
our level best to do the best.
Yes.
And
It is
we are,
very nicely arranged, and I think it will be a great knowledge part for the participants and also for us, because every time education is a new thing, and it's always good to learn something new. So I'm really thankful to all of you to making me a part of this event. Thank you.
ma'am, actually we are trying to keep the physiotherapy at the next level and to bring India on the world level in the field of physiotherapy. That's why we have put it this conference summit as International Web Physio Summit, because all the speakers from the world have joined, and even foreign delegates have also joined in this summit. Last year also we had around 50 delegates from all over the world.
Okay.
So we are
that's a huge number.
Yeah. Around 500 participants were there last year.
Oh, okay.
Yeah, and that was the first summit because no one was organizing. So we had organized in May 30th and 31st of May 2020. This year also we were planning to organize, but due to COVID, many of us have suffered a lot. So that's why we have
that's a big problem now.
Yeah.
Yes, for all of us. But
Dr.
anyways, you
Rishabh,
have arranged it nicely. Yes.
yeah, thank you, ma'am. Dr. Rishabh,
Thank you.
One question for you. Dr. Rishabh, one question for you.
Can you hear me?
Yeah. How effective is FBR in patient of chronic stroke?
See, how effective is, it's up to us how we want to make it effective. It's up to, because there are so many numbers of approaches which we have. It depends on the number of, definitely it will be an effective model, as we have discussed that this it's addressing all the parts of neural plasticity. But again, we need to have a long-term research which looks into how FBR is practiced in a structured way. Right now we have few evidences to it, but it's not in a structured way how we have discussed FBR to be. So we need few research. We need to come up with few research which addresses this. So it depends on how we are implementing. Again, I'm trying to do few case studies. So on case study level, I see a very good improvement into it. But again, we need to come up with few RCTs where we are addressing it in a better way.
Okay, thank you so much, Dr. Rishabh. for being with us. And last year also you were there, and we would like to expect you for being with us in future as well.
Thank you. Thank you. I'm looking forward to the collaboration.
Yeah,
Thank you,
yeah.
sir.
Thank you, sir. Thank you so much. Thank you, Dr. Shekhar Abdullah, sir, for being with us. Dr. Krishna Garg for being with us, and our organizing team, Dr. Saurabh, treasurer and instructor, Academy of Exercise Health and Therapy, as well as Dr. Abhishek, joint secretary of this summit and instructor at Academy of Exercise Health and Therapy. Thank you so much, everyone. And this Neuro Colloquium is over now. And we have the Gynae Colloquium from 3 p.m. to 4 p.m. today. And from 5 p.m. to 7 p.m. Ortho Colloquium will be there. And the same timing will be for tomorrow. The colloquium will be divided like cardio colloquium in the morning, and in afternoon it will be peds colloquium, and in the evening it will be sports colloquium. So thank you all participants for joining. Hope to you all should join in afternoon session in Gynae Colloquium.
Thank you.
Thanks
you,
to all
sir.
the participants, the speakers, as well as the organizing team for having such a wonderful session, and all the best for the future sessions. Yeah. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Thank you.
Pastor, please. Stop the live.
We can sum up the session, Mr. Kostub.
Hello. Yes. Yes.
Yeah, please stop the live stream.
Yes. Yes. I've stopped the session.
Okay. Thank you, Dr. Abdullah.
Thank you.
Thank you so much.
Thank you so much.
Thank you.
Hope to meet you soon in India and Lebanon as well.
With pleasure.
Yeah, Dr. Saurabh and Dr. Abhishek is also there.